Hi, I'm Dr. Alison Kole, sleep medicine specialist and bona fide chronic insomniac. Welcome to the Sleep is My Waking Passion podcast. Remember, knowledge is empowerment, and if applied correctly, it can help you biohack your way to a better night of sleep, just like I did. Hello, everyone, and welcome to another episode of the Sleep is My Waking Passion podcast. I have with me Dr. Caissa Troutman. I am very, very excited for you to meet this woman. She is quadruple board certified. I'm triple boarded. I let my internal medicine boards go. I mean, 3 was enough for me, but not for this lovely lady. We have an expert in obesity medicine. She's also a family medicine doctor. In addition, she has specific education in culinary medicine and certification there, as well as in menopause. And this really is going to be an exciting talk because a lot of this stuff is stuff that I actually feel uncomfortable with as a physician because I didn't get as much background education in that. I've been doing a lot of reading, and I'm hoping that Dr. Caissa can kind of synthesize all of this material and make me a lot smarter by the end of it so I can help my patients who struggle with not only their sleep but also some of the menopausal symptoms that happen. She offers a holistic, individualized approach to sustainable weight loss using the 4M Pillar Foundation Plan, integrating nutrition, physical activity, mindset, and FDA-approved medications for weight. She also happens to have kept off 32% of her own body weight. So this is a person who's living proof of what she is doing. She is not only telling you what to do, she is living that very foundation. So welcome.
Thanks
Dr.
so much
Troutman,
for having
hello.
me.
How
Thanks
are
for
you?
having me, Alison. Super excited about our chat today.
Yes, and she also signed up, and we're listening to what I was talking about with restless legs. And so that's my first introduction. And then I didn't realize that here I am, and one of the audience members is this person with all of your training and your expertise. And I'm happy I could impart any words of wisdom on you with, all of your experience taking care of these patients over the years. It's amazing. She's like 20 years of experience, guys. Yeah. And by the way, if you want to work with her, if you want to check her out, she has a website. It is the Weight, reMDy, reMDy for short, kind of. And all of her links, social media, her website, all of it's going to be in the description. So make sure you check her out especially if you're interested in working with her. Okay. So without further ado, I know today we're going to be really kind of trying to marry some of the issues that happen with menopause, just in terms of the crappier sleep that we get, the waking that we get, and without a doubt, and I'm sure you've experienced this perhaps in your own life, that led you to be able to help others, this sort of sense of, okay, well, it's just part of aging, and, it's just this, it's almost like you're just supposed to accept the second half, if you will, of your life as a woman, just being dissatisfied with where things at.
Absolutely. And I think that is the biggest kind of issue that women are facing, especially midlife women. You're absolutely right. That is me, in terms of, let's just say, the menopause and the sleep and stuff. So my kind of brief story is, I've struggled with obesity most of my life, actually all of my life. I remember pictures of when I was younger, being that chubby kid. I've had the ups and downs. I would lose weight when I'm like on point. And do all the right things and would regain weight. And really it wasn't until like 2016 when I was just like, there has to be a way to really kind of get this off for real. So I dove into obesity medicine, which is, again, a field that really explains to us the brain-based etiology of weight. And that really, it's not my fault, And
I love that. Can you explain that a little bit more about
Absolutely.
that whole connection? Because it's not just about your stomach and what you're putting in and all of that.
Anybody who studies the complex interactions of our brain and our gut understand that the drive to eat does not come from willpower. It does not come from our prefrontal cortex, which is the thinking brain. It really comes from something called the primitive brain or the hypothalamus, which is what sends signals or really encourage the food-seeking behavior, right? So really when we decide to eat, as much as we think it's from our quote-unquote decision or willpower, a lot of it is really based on that survival instinct, the genetic factors, the psychological factors. The analogy I usually use with my patients is like kind of like height is predetermined in a way genetically, right? We don't like think that it's anything weird if somebody has a small. I'm 5 foot, so somebody is 6'1". We don't like bat an eyelash about that. But why is it that when it comes to weight, we just think that it's all about lifestyle choices, and then really it's not. So the old science of calorie in, calorie out, that's super outdated now. Now we know that modern science, it's really about complex interaction, symphony, if you want to call it, of so many things that affect our weight.
Wow. Okay. And so that's the obesity medicine part of it. What happens, because this is going to be as something that clearly you struggle with throughout your lifespan. So this is not just a postmenopausal situation here.
Yeah.
So we're going from premenopause now as we age. What happens in that aging process? How do our hormones even influence our weight?
Yeah, great question. So when we understand that first layer, okay, weight is hard to begin with, right? And then we throw in the complexity of age, and we throw in the complexity of hormonal changes. So let's talk about the hormonal changes. So what we know about menopause is we lose the effects of estrogen, progesterone, and testosterone. What we know about perimenopause is it's the number of years before menopause happens, which is that final menstrual period, just as a definition of sorts. The studies have shown that 2 years before we have our final menstrual period, that is when weight sort of like accelerates, weight gain accelerates. Mm-hmm. So this very same question you're asking, is weight gain because of aging? Is weight gain because of hormonal changes? That's actually been asked several times. And there are actually some studies that really actually try and answer that question. One particular study is called the SWAN study, which is a study of women across nations. It's been ongoing for a while. It's like 3,000 women that they observe from perimenopause up to menopause, right? And in that study, the first thing that they really kind of saw was that weight gain during this time is actually from aging. So weight gain, as change in the number and the scale, is actually from aging. However, one thing that they did notice is the body composition changes. So when we lose estrogen, our body changes fat deposition from a gynoid distribution, which is from our hips, to the abdominal or central obesity distribution. So that's why we have, even though the number on the scale could be the same, our pants are tighter, our dresses are not fitting right.
So we kind of go from, some of us never have that exact body type, but more of a pear shape, if you will, or to more fat around the middle, more of an apple shape. And that, guys, is the part that we don't love in general in medicine, because we know that abdominal girth, how much fat you carry around in your abdominal cavity, does end up impacting risk for all sorts of other health issues, diabetes, cardiovascular disease, etc. So it has some downstream effects that this change in hormone, this lowering of estrogen, is leading to more abdominal obesity, more abdominal fat distribution.
Yeah, absolutely right. There's some metabolic health implications of that increase in visceral fat adiposity. Now, so if you think about it, like we have now increase in fat mass. So let's just say, for the sake of easy math, a 200-pound person, right? When they hit perimenopause or menopause, they will still, they could still be 200 pounds, but they will increase their fat mass. Let's just say, for the sake of example, they were normally 20%, body fat. So that's 40 pounds, right? And then when we go through perimenopause, menopause, that becomes 30% body fat. So now, that's 60 pounds of fat versus 40 pounds of fat. Right? So, but the number on the scale is the same.
Interesting. So you are increasing your fat, and my guess is that the compromise is, if you're staying the same, then that means the composition is changed for more fat, less muscle, is my guess.
Exactly. Yeah. Right.
Because water is going to be water. So
So yeah, so you have that increase in fat mass and increase in fat mass in the visceral area too, right? Deposition,
Around
which
the
then,
organs. That's what
yeah,
visceral means.
yes, yes. And then so that translates to less lean muscle mass. And muscle mass is our engine for of if you want to think about it from a calorie perspective or that energy expenditure perspective. So that's why we when we have that lower lean muscle mass, we tend to kind of gain weight. So it's super complex. It's not just one thing that's thrown at us, right? It's so many other things.
If somebody were to be aging, when would someone with your expertise, when in that process should they be saying, I really need to speak to somebody about this because this is not where I want things to be? There are going to be plenty of women out there who are, I'm going to use myself as an example, like regular routine working out, really watch what I eat or so, and it's a challenge. It is a challenge. Pre-babies versus now, there's certain changes that I've just accepted that are probably not going to go. I can't reverse engineer that, or at least that is the language I'm telling myself because of years of kind of doing the right things and kind of feeling like, well, I'm just maintaining. I'm just sort of treading water here, treading water.
Right.
Now, maybe a little bit more in the middle post-baby than I had before. I'm just using myself as an example,
Right.
but I know I'm not unique here, okay? But sort of feeling like I understand a lot about nutrition, which maybe I'm ahead of the game compared to other people. I understand the importance of muscle mass and weight-bearing exercise, and those are things that I focus on. It's still feeling sort of, it's more difficult. I don't have as much gas in the tank, even though I have a less stressful life. I still really have to work at continuing to, quote, motivate myself to say this is really about my health and longevity, so it's something that I must do. I know my sleep is going to be better when I do these things. I can't be the only person thinking these things. What do we do if we suspect that we're in that season where things are starting to change and we want to maintain our muscle mass? We don't want to, in other words, have this whole change in body composition, and then after the fact, we're like, oh, okay, now what do I do?
Right. That's a very common scenario. I see a lot of that in my patients. And again, it's very individualized, right? You have the patients that are, let's say, have been at normal weight majority of their adult life, and then they gain the weight in that perimenopause transition. Or patients similar to me where I've struggled with obesity most of my life. So again, there's that different hormonal milieu, and then you throw in like midlife hormonal changes. So, and just like anything in medicine, I think it's a very nuanced conversation. However, this is how I usually approach it. If a patient comes to me and the only thing they're concerned about is weight, I can help them lose weight without touching their estrogen, progesterone, and testosterone.
Oh, sorry, I just want to clarify. So even if you don't know exactly where they are in terms of their hormonal levels, weight loss is still possible even if
Absolutely.
you didn't want to deal with the hormones. Okay.
And that's when that 4-pillar approach, which a lot of us obesity medicine specialists, that's what we encourage, or that's the pillar actually that we create a plan with our patients. So that's meals, movement, mind, and medication. And in the past, obesity is deemed a lifestyle issue. Now we know that there really is a biological reason why it's hard to lose weight, and these medications target that biological issue. So can a person lose weight without touching estrogen, progesterone? Absolutely. Now, if a patient comes to me and says, "Oh my God, Troutman, I'm gaining weight. Plus, I'm like, I can't sleep. I'm having anxiety. My mood swings. I'm having hot flashes. I'm having, all the multitude of symptoms that accompany perimenopause and menopause," then you can have a discussion about their eligibility or appropriateness of hormone therapy. So I guess what I'm trying to say is I don't start hormone therapy for just weight alone. But I don't think I've ever met anyone that says that's my only problem, because a lot of us have, again, estrogen and progesterone and testosterone affects so many cells in their body. So, and everybody's journey is different. Everybody's symptoms are different. Like I said, I've never met anybody who says I have no other problem other than weight. In case I do find that person, I'm talking about a midlife person, right? Not a in case I do find that person, for that person, I would do, the 4-pillar approach that I would do for any other patient that struggles with weight.
I'm so curious about because I've known that there are definitely primaries that often will have a lot of patients in menopause that may not have your degree of expertise, but will often check, hormone levels. Are there specific thresholds by which that would be an indication to maybe go and speak with someone such as yourself about eligibility for hormone replacement therapy? I'm not asking for specific numbers, but just a global sense, because I'm going to use the example in sleep medicine just because you were involved in our restless legs conversation, the whole ferritin level. If you were to look at a lab that you just get back and you're uninitiated, meaning you don't have that background knowledge of what it really means, ferritin level could be, quote, normal, and let's say it's 10, which we would consider to be quite low, especially if you're having restless leg symptoms, right? But if you look at the, quote, normal range on a laboratory and you're just looking at what does the lab say it's normal at, right? They're going to be, you can have pretty low iron stores and still be considered normal, even though we know it's not good for you to have those low iron stores. So I'm using that as a surrogate, if you will, to compare it to how do we even interpret the data from hormones? Because a lot of people may just order tests and go, it seems like everything is normal. Is normal normal?
Yeah.
Does that make sense, that question?
It does. And again, I get this question, every single day. And I think maybe let's start with some definitions just to help with that question. So menopause is, again, 12 months after your last menstrual cycle. For those that have a uterus, it's somewhat easy to kind of determine. If for those that do not get their periods anymore for a variety of reasons, endometrial ablation or hysterectomy, then they cannot use that diagnosis. So this is where laboratory, specifically checking for estradiol, is helpful. Oh, side note, by the way, so Menopause Society, our recommendation is really to utilize, if you're going to check estradiol, to utilize blood work and not to do urine testing or saliva testing, which is like the touch test. The position of the society is like, it's not really helpful. Number one, it's expensive. Number two, it doesn't really give you data that's applicable in a clinical setting. So, and a lot of people, including some of my patients, have utilized that before coming to see me. And perimenopause is the years before menopause, right? Average length of perimenopause is 4 years, but it can last up to 10 years. So what I mean by that is this is a very rear view mirror diagnosis. It's not going to help me right now to know, it's not helping me now. Am I in perimenopause? Am I, how long will it be for me before I get to menopause? So the reason I explain that is because for me, I do not need to order estrogen or progesterone or testosterone to diagnose someone in perimenopause.
So you don't need lab work for that. Okay. For perimenopause. Okay.
And the reason for that is because perimenopause is characterized by fluctuating estrogen and progesterone numbers. I want to take that back. I do check testosterone, but not the estrogen and progesterone. And the reason being, so, we call perimenopause the zone of chaos, It's
that is so appropriate. Okay.
Yes. So in a premenopausal woman, like in our 20s, we can pretty much know, okay, estrogen is low in the first day of the cycle, peak goes up, and then we have that ovulation, goes down, and then goes up and down. So when we're in perimenopause, it does not follow the same rules. So you will have super highs of estrogen, super lows of estrogen, right? So if a patient is having symptoms, let's just say, insomnia, hot flashes, mood swings. If I check their level on month 2 and their level is showing me that the estrogen is low, then I could say, yeah, sure, this lab supports your clinical symptoms, right? Yay, okay, that's great, that's perfect. But that's not going to be always the case. You will have patients that you'll catch them at that high level. The levels will be normal, but it doesn't mean they're not in perimenopause. Again, perimenopause is a clinical diagnosis by listening to the patient, listening to their symptoms, and sort of like trying to tie, do these symptoms, if you kind of take them together, are they an indication of estrogen deficiency or progesterone deficiency or testosterone deficiency?
And now a quick break, but don't go anywhere. We'll be right back.
Struggling with sleep? Dr. Kole is here to help. Whether you need a comprehensive sleeping coach program, suspect you have sleep apnea, or simply seek a second opinion, she's available for consultations in New Jersey, New York, California, and Georgia, with more states coming soon. Schedule your free 15-minute consultation today to find out which visit is right for you at asktosleepmd.com and start your journey to better sleep with a trusted physician.
If you are liking this podcast, if you're finding it educational, if you are feeling more empowered to go to your doctor with any sleep issues that you might be having to address them, please, please, please lend your support. Make sure that you are liking, following, subscribing. I am available on YouTube. I'm also on Apple, Spotify, or wherever you get your favorite podcasts. The website has launched. So we have asktosleepmd.com to be your free educational resource. We've added many new blog posts filled with juicy information. If you would like to support the podcast, we now have a way for you to donate. This is a labor of love. I truly enjoy what I am doing. It would be inspiring and truly helpful if you wouldn't mind even so much as donating $1 to keep this podcast going, particularly if you really find this free education a good platform for you and a good resource for you. I also have affiliate links for products that I'm a proponent of, such as Quiet Mind. So please check out the website, sign up, and you will get the latest news, the latest blogs, some sleep tips, and just have a great day and keep listening. Okay, guys, sleep well. So using the clinical presentation or how a patient's describing things, do you then use that as a basis for considering hormone replacement therapy in that patient based just on clinical when they're in perimenopausal phase? I'm curious about that.
Answer is 100%. Now, I will qualify that by, even though I do not check estrogen and progesterone, I do check other other lab work that could indicate other things. So, and that's part of my discussion with my patients is, hey, if you haven't had lab work in let's say 5 years, which a lot of them do because they're usually healthy, then yeah, we need to check your thyroid, we check your CBC, your ferritin, your vitamin D, you should get your cholesterol checked. So it's like basic, there are things you want to rule out if they're normal, and the symptoms suggest that, again, estrogen or progesterone or testosterone deficiency, absolutely, I will definitely start that patient. And that's how I practice.
Wow. This has really, really been helpful because I didn't even know that was a possibility unless you had some sort of, this is very much so in medicine in general. I'll say very specifically to sleep medicine. You feel sometimes that you have we do this a lot in rare disease and sleep where people are too sleepy and we're trying to figure out why, and then they may not quite meet a narcolepsy diagnosis, but they do meet idiopathic hypersomnia diagnosis. But really clinically, what we talk about is, okay, every insurance plan holds their hat on that result of that polysomnogram or that MSLT, but that actually has a lot of limitations to interpretation. So what I'm hearing from you is very, very similar in that the numbers can only tell you so much, so you really do have to rely on clinical diagnosis. Out of curiosity, does that ever impact what gets covered in terms of insurance coverage? Or for someone such as yourself with your expertise, is this type of therapy usually covered by insurance without necessarily having those labs, but with the appropriate documentation?
Oh, yeah. I mean, hormone therapy has been around for 60 years. I mean, generic options are available and they are cheap and they are they're usually my first line. But there are the branded ones sometimes are non-formulary for patients. But to answer your question directly, they do not need a specific lab and it doesn't have to be me diagnosing it, a primary care.
That they could have access to this type of therapy if they needed it, as opposed to some of the firewalls that are put up because I may have a clinical diagnosis that I feel very strongly about, but I might not necessarily have the the results or the test results that 100% corroborate that. There may be a gray area. So it's
Right.
a little bit less for you guys.
Correct. So it's the barrier is not the insurance. The barrier is the misconceptions and myths that are around that makes it hard for clinicians to prescribe it.
Yes. So let's talk about that, because I can remember 20 years ago in medical school, the one thing I could take away from my OBGYN rotation was, oh, we don't give hormones. That is a bad idea. You're going to kill your patient because they're going to get the C word if you give hormones. And now I had this misconception that was burned into my brain as a very young medical student that has influenced me all these years until I moved away from what I do all the time in clinical medicine and went toward actually researching the real literature. And now we're going, oopsie, you've been, all these women all these years have been suffering
Yes.
with all of these symptoms that could have been improved on treatment, specifically because we had this information that wasn't accurate. So can you please kind of debunk this myth for folks? Because I know a lot of women are still very scared about it. And I'm sure there are going to be reasons why hormone replacement may not be ideal for you. And those are very real reasons. But let's kind of open up Pandora's box and really get to some of the misinformation that unfortunately led to millions of women suffering out there.
Right. Yeah. Love to talk about it. So first of all, before we dive into that, definitely just want to emphasize that yes, the treatment is for symptomatic relief, right? That's the main goal. But as an aside, what we've seen with several studies is the health benefits of hormone therapies, especially if it started within the first 10 years of our last menstrual period. Health benefits including decreased cardiovascular, decreased colon cancer, decreased breast cancer, decreased risk of diabetes, and so on and so forth. So the main reason why we've had such a fear with hormones is because of this one study back in 2002 called the Women's Health Initiative study. So that study, just as a sort of like background, came about because at that time, everybody was on estrogen. Everybody was giving estrogen because they knew that estrogen or hormone therapy significantly improved the symptoms of menopause, the hot flashes and all that. So everybody was on that. They did this, the purpose of this study was really more to look at impact of hormone therapy on cardiovascular health. And so because that was the purpose of that study, we need to understand that the participants in that study, the average age was 62 years old. The oldest person in that study was around 78 years old. So we got to remember that the average age of menopause is 52. So these are individuals that are at least 10 years older than the average age of menopause when we would start hormone therapy. So that's the first thing I kind of want to point out. And so what they did in that study was they enrolled patients in an estrogen alone arm, which in an estrogen plus progesterone arm. So the estrogen alone arm was for patients that have had a hysterectomy because we utilize progesterone to prevent that thickening of the lining and prevent endometrial cancer. Now that study was prematurely discontinued 7 years in because they found a quote-unquote, air quote, increased risk of breast cancer in the estrogen plus progesterone arm. So that was the whole debacle where everybody was just like scared of estrogen. The meta-analysis of that same data many years later, so they looked at the same data and kind of looked at it a little bit more in depth. What they actually saw, what they reported in the media was a 27% increased risk of breast cancer. When you hear 27%, sounds high, right? But if you deep dive into the data and look at what we call the absolute risk reduction, the data was actually from 4 out of 1,000 women in 5 years. The risk for breast cancer went up to 5 in 1,000 women in 5 years.
Wow. So the numbers really sounded scary, but really it's not really much of a difference at all.
Yeah.
In reality.
if you look at it, it's a risk, but it's not at 27%. 27% risk is what we call the relative risk, right? And that risk was with the medications they used back then, which is the older synthetic conjugated equine estrogen and medroprogesterone, which is not our first line anymore. We still have it. We still use it, but our first line now is the bioidentical estradiol and the bioidentical prometherum. But there's still there was still a risk, right, for that, but it's not as high as what we were told. Number one, and then in that estrogen alone arm, what they found was actually a 20% breast cancer risk reduction. So less breast cancer in the estrogen alone arm.
Whoa. Oh.
And we've been told that estrogen causes breast cancer, right?
Right.
Yeah. So really, again, the meta-analysis that does show us that it's actually not estrogen, and if you look at it, it's actually the older progesterone that was in that arm that created that. And then to kind of complicate things a little bit more, in one paper I read, it's interesting. What they saw was the reason that the estrogen plus progesterone arm study was higher was likely because the placebo arm of that group had hormone replacement before.
So they weren't even naive. They weren't really a true placebo group.
No, because again, the purpose of this study was not to check if hormone therapy causes breast. The purpose of this study was cardiovascular health. So
wow.
I mean, every time I talk about it, it just blows my mind. And every time I share this data with my patients, they're like, "What?" Like, it just blows everybody's mind, right?
I think they've like redacted that paper.
No, they've done the meta-analysis, and and here's the thing: the data that I just shared, that's been out. That's been out for so long. It's just, again, it's not highlighted.
And so that's one of the things too, guys, is that you hear buzzwords. It's sort of the early 2000 version of what happens every darn day on social media, which is you hear something that sounds very like sexy and exciting and potentially causes controversy or causes fear, and it may not really be true. It's almost like fear-mongering and giving a certain slant on things. So how you hear the data, really just keep in mind that it does impact what your thoughts are about it. And we are very, I think, still very trusting of things that we hear because we want our news to be unbiased and share our stuff. And unfortunately, that's just sort of not how things really are. You're not really just getting the news, you're getting a certain angle or a certain perspective that can shape that. So that is huge. Now, I know that you have limited time with me, so I could literally talk to you for hours.
And talk for hours, right?
I know. I mean, seriously, please. I think we have a lot more to discuss here. This is just the tip of the iceberg. And what I'd like to do is actually bring you back on so we can focus a little bit more on the sleep issues, because we've kind of focused a little bit more on the weight. So I'd love to have you back if you're open to it.
Yeah.
But you had mentioned something to me that I think is really key, which is, you've used medications to help folks lose weight, and then you have the hormone replacement therapy for people who have symptoms. Can you talk a little bit about if there is a hint or an inkling that there may be a synergistic effect between the two? Some medications, the 4M pillar, and then hormone replacement. I'm curious about that.
Yeah, there is. For the longest time, the theory was that hormone therapy does not increase a person's chances of weight loss. That was the prevailing kind of theory. But there was a recent paper that came out in the Menopause journal just this year, April, where what they did note was patients that are on hormone therapy along with a GLP-1, and this particular study was semaglutide. The patients in the arm with hormone therapy actually lost a lot more weight than the one that did not have hormone therapy. Granted that this was a very small study. I think it was it's around 90 patients, so it's a very small study. But it just goes to show that hitting the biology, I think, biology of weight, which is the metabolic hormones, ghrelin and leptin, and like the hormonal or the estrogen and progesterone, just hitting the biological reasons why it's hard is going to be helpful. But yeah, they did show that adding hormone therapy will help with weight loss. Now, the question gets to be, what was the cause? Is it because they're sleeping better? So if they're sleeping better, did that improve the cortisol, or lower the cortisol? So now they're able to lose weight versus when they didn't. So again, it's a very nuanced question. So I think it's just hopefully more studies will show us and guide us into or be able to tell people, yeah, if we add these two together, it's definitely a better combination. But I think in clinical practice, I do that anyway. It would just kind of be nice to see that.
And you're right, it would be nice because it also goes to show that maybe we need to start looking at treatment options, which we are more, right? We're getting much more personalized. Women are getting less and less ignored. Cross my fingers that still continues. We'll see. I feel sometimes like we take one step forward and 4 steps backwards with the state of affairs these days. But the bottom line is that we may be looking at a different treatment paradigm for obesity and later in life for women that might be very different than the approach we might take with men, for example.
Yeah, I hope so. I think it's, I think menopause is having its moment. I think women in general, we're advocating for ourselves. I think I think the time is here. And I'm just hopeful that it will become more accessible and more people, more clinicians will be aware. Because until now, I get patients that tell me like, oh yeah, my provider didn't want me on it for, a variety of reasons. Again, myths and misconceptions is still abounding.
It really is. And I've had people say, I want to really go a more natural route. And I see hormone replacement as being sort of natural in essence. We're made of hormones. So, but there's still a lot of reticence about that. Are there any absolute contraindications? So what that basically means is, oh no, we shouldn't even be going there. Like, unfortunately, it ain't going to be for you. What are some real things that are like, listen, I wouldn't even talk about hormone replacement therapy because it'd be easily not the right thing for certain women. Maybe if they just know that right off the bat, it sort of saves them time in terms of stressing and worrying am I a candidate and going down that Dr. Google rabbit hole that so many people do.
Yeah, so there's definitely contraindications. Now, I did want to kind of comment on that because there's different forms of estrogen therapy. There's transdermal, there's oral. So the common issue, I should say, the number one adverse effect is blood clots, which is very real. Although, as an aside, the risk of a blood clot from hormone therapy is a lot less than the risk of a blood clot from oral contraceptives, much, much lower. So a person that has an unprovoked blood clot or unprovoked pulmonary embolism, stroke, heart attack, because again, it's about clotting, would not be an ideal candidate for hormone therapy. Anybody that's having vaginal bleeding and we don't know why yet, they would not be a good candidate. They need to kind of get that figured out first. Any suspected breast cancer that not indicated at that time. And again, that's a very nuanced discussion, right? We just talked about it's actually protective. And estrogen does not cause breast cancer, but if a person has breast cancer currently, it can make that breast cancer grow. Does that make sense?
Right,
yeah.
Because there are, estrogen receptors and things
right.
like that can, depending on the type, right?
Right.
There's different types, but right. Yes.
But it does not give them breast cancer, which is what we've been told. And of course, if they're pregnant, so can't have hormone therapy. Just thought I'd throw that in there.
I love that because, as we know, pregnant women are often like, "Oh, that's an oopsie. We won't go there in that clinical trial." Yeah. This has been seriously such a helpful discussion to myself. I cannot imagine that listeners out there aren't going to be like, whoa, let me really think about this. I said when I was introducing season 5 in my teaser that this is, we sort of touched on, this is definitely sleep related, because we've mentioned that hormones really can impact the quality of your sleep.
Yes.
And your ability to sort of stay asleep and fall asleep. So we get that insomnia, which is what's happening, which is a lot of sleep disruption that's very common. But it's also somewhat sleep adjacent, and the conversation today was more sleep adjacent. But the reality is that in addition to not sleeping as well, weight gain really increases your risk for obstructive sleep apnea. The hormonal changes tend to disrupt the stability of our upper airway. There is some data that tells us that our hormones like estrogen and progesterone can actually be somewhat protective of the upper airway in terms of stabilizing the musculature. So I think, again, you highlighted the fact that this is such a complicated issue, very, very complex. But if anything, if we can get you optimizing your health, yes, I want to optimize your sleep, but part of it is how do we optimize other areas of other aspects of your life that really also end up being very protective of your health in the long run, hopefully, right? There's no crystal ball here. It's not up to us. But if we can do smart things to try to increase the odds that we're on the planet longer, living a healthy, good quality of life, oh, amen. I'm all about that.
Absolutely.
Thank you so much. This was so fun. I must have you back on. Seriously, you're a wealth of information.
Yeah. Thanks for having me. So much fun to talk about. As you can see, I'm just like, yes.
And that is why I do this. This is the highlight of my day. Now I have to actually go and do some real work, you know? Disclaimer. The statements made on this podcast have not been evaluated by the U.S. Food or Drug Administration. They are not intended to diagnose, treat, cure, or prevent disease. The information provided by this podcast should not be used as individual medical advice. While I am a practicing sleep provider, I am not your sleep provider. You should always consult with your personal healthcare provider for individual recommendations and treatment.